So this will be part 2 of the newborn GI disorders. We're going to look at two sets of disorders that are frequently confused by students, Omphalocele and Gastroschisis, and Meconium ileus and Meconium plug syndrome. And then we'll also look at congenital diaphragmatic hernia. So the omphalocele is a defect of the abdominal wall musculature, and this causes protrusion of the abdominal viscera, the intestines namely, through the umbilical cord. And in this case, the visceral organs are generally visible, but there's a very obvious protective sac over them. You can diagnose this antenatally via sonography, and that almost is always the case because mothers go in for their checkups, or at least they should. And if you know in advance that the baby has omphalocele, then you're going to want this baby delivered via C-section and in a facility that has neonatal care service. This is associated with trisomies, Beckwith-Wiedemann syndrome, neural tube defects, cardiac defects, and other congenital anomalies. So at 13 weeks gestation, or by 13 weeks, actually by 12 weeks, at 12 weeks of gestation, all of the abdominal viscera, the intestine that have hitherto been developing outside of the abdomen, at 12 weeks they should come back into the abdomen and be closed inside the abdominal wall. So after 12 weeks of gestation, if you see something like this, this is abnormal. And so what you see here is the omphalocele. You see all the abdominal contents out here. You can see a lumen right here and right here. So this is omphalocele. Now, if you were to do this at 11 weeks gestation and you saw this, then you can't diagnose that because all of this stuff is outside of the abdomen until 12 weeks of gestation. This is what the omphalocele looks like. And so this is that protective sac that covers the viscera. And that's going to really help you distinguish this from gastroschisis. Here's another one. So there you can really see, it almost looks like a brain, but it's not, small intestine. So the treatment here is, of course, you want to have pediatric surgery on board because they're going to be helping you with the closure. You want to immediately cover the exposed viscera with moist and sterile gauze to prevent fluid loss and infection. And on the USMLE, if they ask you what's the best initial step, it's this right here. So cover the exposed viscera with moist and sterile gauze. You can do NG decompression, start IV fluids and nutrition, and then these babies usually are admitted to a NICU to start off, or some kind of a pediatric surgery unit. The complications of this include respiratory compromise and compression of the inferior vena cava. Gastroschisis is a bigger problem. It's sometimes confused with omphalocele. This is also due to a defect of the abdominal wall, and this results in free herniation. And that's the difference from omphalocele. With omphalocele, you have a herniation through the umbilicus. You have a protective sac. With gastroschisis, you literally have bowel just coming out. So in gastroschisis, you don't have a protective sac, and therefore the viscera are in acute danger. And this is what makes gastroschisis a lot more problematic. You can get necrosis and infection and peritonitis and all that good stuff. So this is associated with trisomies. About 50% of these babies are also small for gestational age. Can also be diagnosed antenatally via sonography, so you'll want to take precautionary measures, preparatory measures, if you have diagnosed it antenatally. And the major complication from this is chemical peritonitis and sepsis, which will destroy the bowel. So here's gastroschisis, 35 weeks of gestation, and you can see bowel outside baby, not good. And the baby's born, and no protective sac here. So this is gastroschisis. This needs to be covered up ASAP. Like this. Here it's covered up. You should cover the whole thing up though. So again here, the management is pretty similar to Omphalocele, except it's just a little bit more emergent and we're concerned about peritonitis. So you immediately cover the abdominal contents with a moistened sterile gauze or some kind of covering that's approved. And you'll do NG decompression, IV fluids and nutrition, broad spectrum IV antibiotics. You want to prevent peritonitis, you want to prevent infection of the bowel because that's going to lead to necrosis, and that's what brings you your morbidity from gastroschisis. So something like ampicillin, gentamicin, piperacillin, tazobactam would be good to get your broad coverage and help prevent this. These babies are typically admitted into a NICU, and urgent surgery is done very soon, 24 to 48 hours, and this is a staged closure. There's a lot of abdominal contents that need to be put back in, so typically needs to be staged. But these babies need to stay in the hospital until this is totally closed up. A congenital diaphragmatic hernia is a failure of diaphragmatic tissues to fuse properly, and this results in a defect that allows abdominal contents to herniate rather than outside the body here. It herniates into the thoracic cavity. And usually this happens on the left. Why does it happen on the left? Well, on the right you have a liver. So that liver is protective to help keep things down in the peritoneum. On the left, though, you just have diaphragm. So typically, when you have a defect, it's going to herniate onto the left side if there is a defect. The primary problem here is not so much bowel-related, it's respiratory insufficiency. And the reason is because you have so much compression. You've got probably total hypoplasia of the lung on the affected side, and then on the non-affected side, there's also reduced ventilatory capacity. So this can be diagnosed prenatally in ultrasound. If the diagnosis is made prenatally, obviously, again, mom should deliver in a hospital with a NICU, and ped staff or neonatology should be already in the delivery room to attend to this baby. Symptoms are respiratory distress, scaphoid abdomen. Why a scaphoid abdomen? Well, you've got bowel contents going from the peritoneum into the chest cavity. And so all that stuff that's supposed to be in the abdomen is up into the chest cavity, and so you have a flat or scaphoid abdomen. And then what do you see in the chest, or what do you hear in the chest? You'll hear a shifting of heart sounds to the right because you're pushing the heart over to the right side of the chest. Tachypnea, that just relates to the respiratory distress. Use of accessory muscles, nasal flaring, cyanosis, and then on the affected side you may hear bowel sounds, but you certainly won't hear breath sounds on that side. The best initial diagnostic test here is a chest x-ray, and that will show the abdominal contents in the thoracic cavity very clearly, and also the shifted mediastinum. So this is very easy to diagnose on chest x-ray. So if you have a baby in respiratory distress, the best initial diagnostic test is pretty much always going to be a chest x-ray. And here you can see it. You got the bowel up here, which should be down here, and you've got the heart way over here, which should be more over here, where these intestinal contents are. So the management is going to be to alert surgery. These babies need to be intubated, but their mechanical ventilation needs to be gentle. One of the biggest problems here is mechanical ventilatory damage. And so it's actually okay, and typically an intensivist is going to make this call, but it is generally okay to allow a little bit of hypercarbia in these babies because you want to be very, very, very gentle on their lungs. And in some cases, they may even be put on ECMO, which in that case, you're totally bypassing their lungs altogether. And what you need to do is you need to let these babies develop a little bit. You delay the surgery for a couple days, and this improves the pulmonary hypertension that they all have because when you have a compressed chest cavity, you're going to have you're going to have pulmonary hypertension. You've got all this pressure pushing on the heart, pushing on the lungs. So you want to allow the pulmonary hypertension to recede a little bit. It won't go back to normal, but you let that improve a little bit, usually a couple days, and then surgery can be done. But also, please remember that the ventilation needs to be sufficient, but it needs to be gentle. And then, obviously, these babies aren't going to be feeding. They're going to be on IV fluids and glucose, and they're going to be in an intensive center. And the survival is improving with CDH. It used to be dismal. Now it's 75 to 80%. So the first step is intubation and gentle mechanical ventilation. Meconium ileus is an impaction of meconium, which is overly thick and tenacious, and it is in the distal small bowel, typically the terminal ileum. It can also, in some cases, be in the cecum. So why is the meconium thick and tenacious here? Meconium is typically not, I mean, it looks kind of thick and gross, but it's typically not thick and tenacious. The reason is, in most cases, because of cystic fibrosis. Remember, cystic fibrosis is a defect in a chloride channel, and that chloride channel helps with osmosis. And so because of that defect, you have thick secretions, and that is something you see everywhere in cystic fibrosis. It's the reason cystic fibrosis patients have a higher risk of lung infections. And so that same reason is what causes their meconium to be really thick and nasty. And because it becomes so thick, it can actually cause impaction and subsequently obstruction. So these babies will have abdominal distension. They'll have bilious vomiting because this obstruction is lower. They certainly will have failure to pass meconium. They'll also, in some cases, have respiratory complications from the severe distension, pushing on the diaphragm. So the best initial diagnostic test in pretty much any baby with failure to pass meconium or abdominal distension is an abdominal x-ray. That's going to show multiple loops of small bowel. What does multiple loops of small bowel mean? It just means a more distal obstruction. And you also may see a soap bubble appearance. And this soap bubble appearance is not pathognomonic for Meconium ileus, but there's a high association. This should be followed by an upper GI contrast study and a contrast enema. And the contrast enema will demonstrate a microcolon. Why a microcolon? Because you have an impaction of meconium at the terminal ileum or at the very beginning of the large intestine. So everything distal to that is not being used. And so it's a microcolon because it's not being used. You may see insipated meconium at the terminal ileum, but it's hard. It may be hard to see. I wouldn't rely on that. But the microcolon on contrast enema, in addition to all of these other signs and the abdominal x-ray with multiple loops of small bowel, is what's going to help you make your diagnosis. But you need to get the contrast enema. So here's Meconium ileus. You can see some of the soap bubbling up here. In here, and this is just the abnormal meconium. Then multiple dilated loops of small bowel. Remember, you have that. And then when you do your contrast enema, you'll see a microcolon. So this should be, usually it's a lot thicker than this. And then these little filling defects are little pieces of meconium. And remember, meconium is not stool. It's meconium can be just small pieces of cellular contents and mucus. Okay, so microcolon. So the management here is actually the same as the diagnosis. So while you're doing your diagnostic enema, in most cases, you're actually also going to be able to treat the patient as well. In some centers, they will add N-acetylcysteine or NAC to the fluid, and that is thought to help dissolve some of the meconium. but you don't necessarily have to do it. The literature is not contradictory, but it doesn't say that you necessarily have to add NAC to it. But a lot of physicians do. And the diagnostic enema will actually relieve the Meconium ileus in about half the cases. It will actually dissolve that obstruction. If it's unsuccessful, and I'm not exactly sure how many times you do the enema before you decide to go on with a laparotomy, but after a few attempts, if it's not been successful, then you'll go on to send these off to surgery for laparotomy. Okay, so here we have Meconium plug syndrome. This is not the same as Meconium ileus, and let me try to explain the reason why. So with Meconium ileus, which we just talked about, the problem there is the meconium. The meconium is abnormal. It's way too thick, more thick than it's supposed to be because of the cystic fibrosis problems, and you just have thick secretions overall. So the meconium is thick, and therefore, because it is so thick, it winds up causing a blockage, and that blockage is in the distal small intestine. With Meconium plug syndrome, the problem here is not the meconium. The problem is a functionally immature intestine. And so because the intestine, the large bowel, is functionally immature, the meconium doesn't pass properly. And so it becomes backed up and forms a plug. And so you have this plug of meconium, even though the problem, unlike its name, is not the meconium. It's functional immaturity of the colon. Okay, so it's kind of a deceiving name. This is not, the meconium plug is there, but the meconium plug is secondary to a functionally immature colon. So that's what really makes this different from Meconium ileus. In Meconium ileus, it's the meconium that's abnormal, and it's the meconium that's causing the backup. It's causing the obstruction. In Meconium plug syndrome, it's the large bowel that's functionally immature, and so the meconium is getting backed up because it can't pass properly, and so it forms a plug, and that plug is then seen when you do the enema to look for the problem. Okay, so what is this associated with? Remember, Meconium ileus is associated with cystic fibrosis. Meconium plug syndrome is associated with infants of diabetic moms, as well as moms who are on magnesium sulfate. Remember what magnesium sulfate is used for? It's used for moms who have preeclampsia. So to differentiate this from Meconium ileus, on your contrast enema, remember you should get an abdominal X-ray first when you've got a baby who has got obstruction and hasn't passed meconium and is bloated. So the abdominal X-ray is going to show you multiple dilated loops of small bowel, and then you get your contrast enema. And with Meconium ileus, remember you're going to see a microcolon. Because you've got blockage before the colon. The colon's not even being used. With Meconium plug syndrome, you're going to see a normal colon, but you've got all that insipated meconium that's plugging it. And so that's really what makes the difference from Meconium ileus. But they both cause failure to pass meconium, they both cause bloating, so they cause similar symptoms, and coincidentally, they have similar treatment too. Now, another thing that's important to differentiate this out from is Hirschsprung's disease, and Hirschsprung's disease typically affects the rectosigmoidal area, and so if you're not sure, you should get anorectomanometry or rectal biopsy, and that will provide a definite rule out. Actually, in reality, you should get an anorectal manometry in any baby with Meconium plug syndrome because there's a significant overlap. A lot of babies who have Meconium plug syndrome tend to also have Hirschsprung's disease as well. Diagnosis is a contrast enema, as mentioned, and so this is what it looks like. You see, this is certainly not a Meconium ileus. This is not a microcolon. However, in a lot of cases of Meconium plug syndrome, the left colon may be micro. So that and that's typically due to the plug, and so it's plugging everything up to the left colon. So in this case, you do have a more micro left colon than the rest of the colon. And here you've got a much wider, much longer plug. See, all this filling defect is meconium. It's backed up because the colon's not working properly. Again here, well, I would say the left colon is a little bit micro here too. So this is meconium plug syndrome. Okay, so management. Like I said, this is diagnosed during the contrast enema. You can add N-acetylcysteine to the fluid, which kind of helps break up the meconium, and in most cases, that is actually therapeutic. But because of 10 to 30% of meconium plug patients also having Hirschsprung's disease, we also like to do anal rectal manometry on these babies, and that will help us rule out Hirschsprung's disease as well, because they could have both. But few patients will actually require surgery from this. Most babies, 90%, are going to be successfully treated with the enema.